So we will go to the last presentation. Dr. Nikita GUPTA will give a talk on RPE tears to inject or not.
Good morning, everyone. The topic of my presentation is RPE tears to inject or not. One of the rare and more dreaded sequelae of CNVM are RPE rips or RPE tears. So we did a retrospective observational study of 5 eyes with spontaneous RPE tears or those formed following anti-VEGF treatment and looked at their management over 1 year. 5 eyes of 5 patients were taken, OCT confirmation of the tear was done, intravitreal anti-VEGF agents were given in all these patients and the response assessed over a minimum period of 1 year. Coming to my first case, it was a 64-year-old female who presented with diminution of vision in her right eye with a BCVA of 6/12. She had a large PED with a height of 503 microns and a basal dimension of 2860 microns. She also had some subretinal fluid. The patient was injected with injection Eylea, and 1 month later, the patient's vision, although improved to 6/9 parts, however, we could see a clear-cut area of RPE tear just falling at the fovea. You can see this area of bare choroid and the RPE scroll at the fovea. The patient still had some SRF and the patient was re-injected with Eylea. However, this time the visual acuity did not improve. It was 6/24. However, there was no fluid. The patient did fine for next 3 months, again, after which she again developed fluid. And again, she was injected with Eylea. And her visual acuity came back to 6/24. And this same happened in December. After 2 months, she again developed fluid. We re-injected. And at the end of 1 year, her visual acuity actually dropped from baseline 6/12 to 6/36. As you can see, the RPE tear was just at the fovea and there is some scarring also underneath. So from this case, we learned that although every time fluid came, we re-injected the patient and the patient did improve. However, if the RPE tear is involving the fovea, vision does not significantly improve with treatment. Coming to my second case of a 60-year-old male who presented with diminution of vision in his right eye since 2 months. The patient's BCVA was 6/60. There was no history of any injection of anti-VEGF or any laser done. We can see an area of RPE scroll with an area of bare choroid on either sides of the RPE tear, and the other side had drusen's. You can see the area is better appreciated in autofluorescence. There was a lot of SRF and IRF, and we injected the patient with Eylea. And 1 month later, the patient was very happy, and the visual acuity improved to 6/12. And the fluid had nearly gone. There was some SRF. We re-injected. The patient was maintaining 6/12 for the next 3-4 months. After which, again, he developed the SRF and IRF. We re-injected the patient. However, this time, although the fluid disappeared, the visual acuity had actually dropped down to 660. Probably this is secondary to the scarring that has happened underlying the CNVM complex. Even though the RPE was intact under the fovea, the scarring had led to a drop in vision. We can see the scarring under the RPE as well as in the area of bare choroid as well. At the end of 1 year, the patient had a visual acuity of 660. That is a drop from the baseline. So from this case, we learned that if the RPE rip is not involving the fovea, vision is usually not affected till the time CNVM's complex starts to scar. However, every time if the fluid is resolving with treatment, we should treat the patients with anti-VEGF agents on a PRN basis. Coming to my third case of a 77-year-old male who presented with diminution of vision in his right eye for 1 month. The BCVA was 6/9. You can see a large PED, some SRF and IRF. The patient was injected with Eylea. The patient had improvement in visual acuity 6/6. However, there was some hyperreflectivity under the fovea, but no clear-cut RPE rip. However, 1 month later, the patient had again an RPE rip falling just short of fovea. The visual acuity was maintained to 6/12. You can see the area of RPE rip. There's bare choroid in this area. It was confirmed on angiography as well. The patient was injected with Eylea. 1 month later, the patient, after the effect of the Eylea probably subsided, the patient developed fluid. But every time we injected the patient with Eylea, the patient's visual acuity remained 6/9. There was fluid, but it never increased. However, this time there was fluid on the nasal side of the RPE rip also. We gave the injection on 24th June, and just 1 week later, we repeated the OCT just to find out whether the injection is actually working. And we did see that there's a slight decrease in the SRF on either sides of the RPE rip. And 1 month later, the patient again developed a recurrence of fluid, and we again re-injected the patient. However, we kept increasing as the fluid was never reaching under the fovea, and every time we kept increasing the interval of injections from 4 weekly to 5 weekly to 6 weekly, and then ultimately this patient has been on a 2.5 year follow-up and is now on 8 weekly injections, and the patient has been maintaining a visual acuity of 6/9. So from this case, we learned that RPE rips usually tend to move towards the fovea, and once they form, they usually don't extend further. And if the fluid is not resolving completely but is remaining stable, we can actually switch to a treat and extend regimen. I'll skip my last case. It's just of RPE rip involving exactly the fovea, and the patient's visual acuity was finger counting close to face after an injection of Eylea. And at the end of 1 year, the patient did not improve very significantly because the RPE rip was involving the fovea, but did maintain his vision. So And so out of my all 5 cases, 3 of them, that is 60% of the cases, had a visual acuity improvement or stabilization at the end of 1 year, while the visual acuity worsened in 40%. Worsening of visual acuity occurs when RPTs either involve the fovea or when scarring develops under the CNVM complex under the RPE. So the take home is that do not always treat at all in bullous PED if it is threatening but not involving fovea, as these cases are at high risk of developing an RP tear and vision might be permanently affected. However, if there is fluid and you have to treat at all in bullous PED, anticipate the chances of an RP tear and explain that to a patient. More importantly, it is important to identify when an RP rip occurs and prognosticate the patient accordingly. And as long as vision improves or remains stable and there are persistent exudative changes noted with the RPTR, do not hesitate to inject further anti-VEGF injections. Thank you.
So what should be the cut limit of visual acuity? As in one case here, the previous pre-injection vision was 6/9.
Yes.
And after the injection, the rip occurred and the vision dropped to 6/12. And patient must be complaining in those cases.
Now, actually, I don't feel that there's a cutoff of visual acuity. As long if the RPTS has already occurred, then you have to explain the patient that the visual acuity might not improve even.
It means the pre-injection counseling is very important.
Yes.
In where you have a big.
Wherever there's a
PED,
tall bullous PED,
bullous
just
PED.
anticipate an RPTR and explain
What is the take-home message from you? You are telling that even if there is RP rip, you have to continue injecting.
Yes, sir.
Then in the conclusion you have written, large PED where there is a risk you should not inject. How can you conclude that from your 5 cases already?
So I'm saying if there is a tall PED and it is not
That is
involving
not a conclusion from this study. That's a general conclusion. So
It's
this
a
is
literature conclusion.
literature
Yeah, it's
conclusion.
literature.
That is still controversial.
So any cutoff points you use as a visual acuity?
So not for
For
visual
injecting.
acuity, but basically literature says that if this is the PED height is more than 500 microns, or if it's a recent onset PED less than 4.5 months history, or if the greater basal dimension is too much, there's no cutoff for that. For height, there is 400 microns. Then you should anticipate, and if these are high risk factors. And
It's a vision is 6/9. Should you inject or you should wait?
so if the patient, if that's what I'm saying, if counseling is very important. If the patient understands that there is a chance
I
of
think
rip
we
and
are
he's ready.
deviating from actually the message of the study is you have to keep on injecting even if there is RP.
Should not
Not
quit
the
dosing.
yeah, that is. So anyway, thank you, madam. Anything?
Ma'am, there's a question.
Subhadra madam's comment will not be counted for mark. Don't worry.
Marks just to have what I do. We have published also that these tall PEDs we should treat with oral steroids for 4 weeks. Everything flattens and then you can inject. Never inject with that big PED, because if you don't inject, the CNVM will worsen. But you give them steroids 4 to 6 weeks, everything goes away. Even nowadays I give IVMP for 3 days and then few weeks of oral steroids. Everything goes away, whether it is PCV, whether it is hemorrhagic PED, anything. They really do well. And this is based on the histopathology of some of these eyes, which was published way back in 1970s by Green from Johns Hopkins, that there is inflammation in these eyes. We already know there is inflammation in CRVO, we are giving Ozurdex. So even these eyes, they have a lot of inflammation, give steroids, you will see dramatic change in your outcomes.
Thank you, madam.
Ma'am's remarks are learning remarks for all the audience.
It is
So the
published.
next